First off, thank you for coming on such a beautiful, beautiful Saturday. Thank you for lasting till the end of the day. And I really appreciate you guys being here at 4 o'clock on a Saturday when it's been already a long day. So hopefully this is useful for you. I know this is your time, so if there's anything that you want to ask me, interrupt, anything you want to share, you want to tell a story, you want to show me a picture of your puppy, whatever it is, share and speak and interrupt and do whatever it is that you need to do to make this time useful for you, because this is your Saturday afternoon that I have the privilege of sharing with you. My name is Kathleen Maignan. I'm a nurse practitioner currently at Weill Cornell Medical College. I work in the bone marrow transplant outpatient department, but my entire nursing career, ever since I was a baby nurse, has been in lymphoma and focused on lymphoma patients. Now in a little bit different of a setting, but still, I'm much older than I look, hopefully, but it's been about 15, 16 years that I've been working with lymphoma patients. So I know a few things. You guys probably know a whole lot more. So anything you want to add to what I'm saying here, please feel free to interject. So we're going to be talking about treatment side effects. As you know, the most difficult part of cancer treatment are the side effects. And what we're going to talk about is trying to find ways to mitigate them, really. That's what the ultimate goal is. But we're going to talk about why they happen, how they happen, and how we can prevent them or stop them in their tracks. Any questions so far? Okay, great. So we'll start off with why do these side effects occur? We'll talk about the types of chemotherapy or treatments that you might be getting and the kind of side effects you're going to see from these different groups. And then we'll talk about comorbidities, really like what's your baseline? What are you bringing to the table? And what are the things that about you that might make treatment difficult? And then we'll review the actual side effects. And then we'll talk about how to mitigate them and how to manage them and get through this process. So, before I talk about anything specific, if you're on therapy, no matter what's going on, anything, your toenails are itching, your eyelashes turn green. It doesn't really matter what happens. You need to let us know, and you need to let us know as soon as possible. I can tell you about all the most common things that happen to all the common people, but you are a party of one. You know yourself better than anyone else does, so if something different is going on with you, it's really important that you let us know so that we can help you through that. So let's talk about comorbidities. Most patients that I work with are adults. I work with adults exclusively. Hodgkin's patients tend to be a little bit younger, and the advantage that they have is that they have fresh, young kidneys, a young heart, a liver that hasn't been tested by, copious amounts of alcohol. Unfortunately, for older patients, we have things that we bring to the table that are challenging. Perhaps your kidney function isn't great. Perhaps your heart isn't as strong. You may have high blood pressure or diabetes. These are things that you really do need to discuss with your physician before coming in, because it may affect how we decide to dose your treatment so that you don't experience as bad side effects. We also may need to alter your medications as we go along to work with the therapies that we're giving you, especially if there's competing interests. So let's just say you're on a medication that's very taxing on your kidneys. We may decide to use a different chemotherapy that doesn't utilize your kidneys as much. When it comes to side effects, everything is related. It's one whole body. And while, us providers were guilty of focusing on one body part at a time, everything is affected. And that involves the drugs that you're on, the chemotherapy that you're getting, the comorbidities that you already have, whether you stop or start a medication. Sometimes the side effects are worse when you actually stop something. So, for example, if you're on a steroid, and you're on it for a few days and you stop, you may feel really, really tired. And that side effect may be worse than actually feeling like you're on the steroid, the side effects that you get from that steroid. And so now, why do we even have these side effects? So the way chemotherapy works, traditional chemotherapy, I'm talking about like alkylating agents, the stereotypical thing that you see on TV. The way chemotherapy works is it alters the cell cycle of your fast-growing cells. Chemotherapy affects cancer cells because cancer cells, they're very disorganized. They grow really quickly. They don't really have a plan. They don't know when to stop growing. And there's no roadmap for what they're going to do. So it's very easy to disrupt a cell that is so disorganized and so fragile. And they're also very, very fast growing. And so with chemo, the way we decide to dose chemo and the way we do the timing, we want to say, okay, how can we kill as many cancer cells as we can without killing healthy cells and giving healthy cells time to recover? Healthy cells will recover. Cancer cells don't recover as quickly. While they may die very quickly, they don't recover as well. So if we say, all right, we're going to give this every 2 weeks, the reason why we decide on 2 weeks is that 2 weeks allows cancer cells to die, but it gives enough time for your healthy cells to grow. So the cells that grow the fastest in your body are the cells in your hair, the lining of your mouth and your gut. Also, your skin grows really quickly. So that's where you're going to see the most side effects. That's where you get the nausea, the hair loss, the GI irritation in your stomach, diarrhea, those sorts of things. Also, your bone marrow grows really quickly, and we'll talk about how your bone marrow affects everything. So this is the cell cycle, and basically, depending on the type of chemotherapy that you're getting, it's going to kill the cell in one part of the cycle. The other symptoms that you may feel may be related to the disease itself, the lymphoma itself. Why is lymphoma annoying? It's like a bad house guest. These are cells that multiply and multiply. They eat all your food and make you tired. They crowd out your marrow and prevent your marrow from making healthy cells. They crowd out your lymph nodes and prevent them from doing what they were born to do, which is help prevent infection, help filter out things that don't belong in your system. And so it's just a bad house guest that's getting in the way of you feeling your best. So the lymphoma itself already is going to make you feel not so great. So now, to combat that lymphoma, we have different types of agents. The first agent, alkylating agent, again, is what you probably think of when you think of chemotherapy. It works directly on the DNA to mitigate cell differentiation and proliferation, meaning it stops cells from dividing, stops them in their tracks, and stops them from growing. And it kills cells in all different phases of the cell cycle. And so when you think of this, you can think of drugs like cyclophosphamide, which you may have heard of, or carboplatin. The second group are anti-tumor antibiotics, but these are actually made from microorganisms, from different types of microorganisms, and it doesn't act like antibiotics that you're familiar with, but it does a very similar thing in that it stops the DNA and alters the DNA to stop the cells from growing. An example of this is doxorubicin. So doxorubicin is known for causing a lot of nausea, hair loss. It basically blanket treats every fast-growing cell in your body. And then there are vinca alkaloids. Vinca alkaloids actually come from plants. So these were found on a plant, and now they make a synthetic version. And what's interesting about this is it has they all have a similar mechanism of action in that they cause a lot of constipation and neurological issues. So peripheral neuropathy is a big issue with these vinca alkaloids. And now we talk about the newer forms of treatment. So I gave this talk 2 years ago, and of course everything has changed since then. We have immunotherapy, like Rituxan or brentuximab. What's very interesting about this is that everybody has antibodies. Antibodies are directly targeted to certain antigens in your body. And so these are engineered from actual animal sources. Rituxan is from mice. Brentuximab is from Chinese hamster ovaries. So they get these antibodies, and they are directly targeted to proteins on your lymphoma cells, either CD20 or CD30, depending on the antibody. What's great about these is that it's like a heat-seeking missile. It targets the lymphoma directly, but there are still some side effects. And while they may not be the traditional side effects, they may make it easier for you to have infections. They may cause some fatigue as well, but the side effects are a little bit different. They're HDAC inhibitors like romidepsin, which they give for CTCL, immune modulators, which are popular now because these are oral options like Revlimid, ibrutinib, Zytilig, but they can also increase risk of infection. Pralatrexate, which can cause some mouth sores, and the way that works is by interfering with your body's processing of vitamin B, and that's how it kills the cancer cells. And then we have the newer therapies, immune checkpoint inhibitors. So you may have heard of PD-1, PD-L1 inhibitors. Those are nivolumab, pembrolizumab, or Keytruda, Opdivo. Those work by firing up your own immune system to fight off infection. And again, there are some side effects with that. And firing up your own immune system can attack healthy cells. So don't worry, this is not all bad. We're going to talk about good stuff too. Sorry, I see everybody's face just going, oh. But yeah, it preserves most healthy cells, but there can be some autoimmune related side effects like hepatitis or some kidney issues. So, talking about this, these side effects can affect your entire body. It's one big network. So again, your immune system, you may be more susceptible to infection. Your heart may be affected if you're taking something like doxorubicin, which can affect the beating of your heart. Your GI tract, even your muscles, digestive system, hormones, and most importantly, which we're going to talk about in a little bit, is your bone marrow. So in your marrow, you make all of your blood cells. There's a network of stem cells, and they can grow into just about anything, which include red blood cells, which we'll talk about what they do, white blood cells that fight off infection, and platelets that stop from bleeding. So because bone marrow grows so quickly and those cells multiply so quickly, myelosuppression is a big side effect with a lot of different types of chemotherapy. It's expected, but you may not see the effects right away. So you won't get chemo and then automatically drop your count. So it usually takes about 7 to 10 days, sometimes almost 2 weeks. And you'll see a decrease in your white blood cells, red blood cells, platelets, either all or one or a combination of them. And with your first cycle of chemo, no matter what it is, oftentimes we do a CBC pretty soon after just to see exactly how quickly this is happening and how long it takes you to recover. Because we want to know, is this delayed? Is this continuous? Is this something that we need to continue to monitor over time? So just breaking down into the 3 different types, you've got anemia. Anemia is a reduction in your red blood cells. What your red blood cells do, in a nutshell, they carry oxygen. That's their most important function. So they travel through your lungs, and the red part of these cells, what makes them red, the hemoglobin, actually carries oxygen around, which provides energy. So we check this with a CBC, whether it's your hematocrit, which tells us how much, what the volume is, concentration in your blood, or the hemoglobin itself. So we're not counting the actual red blood cells. So if you do become anemic, and if it's something that we expect, there's easy ways to just deal with what's going to happen. So if you don't have enough oxygen, right, your energy is not going to be so great. Expect to be a little bit tired. So those are the days that, you may just not want to do as much. You want to conserve energy. Don't overdo it. And as you change positions, just going from sitting to standing, again, you don't have enough red blood cells traveling along to help with position changes, so you may feel a little dizzy. That's when you really want to be careful about changing positions. Diet is really important. You want to make sure you have some source of protein. I'm not a huge meat eater, and I don't say you have to go eat meat, but any good protein sources, whether it's vegetable or meat, you should try and beef that up if you can. Now, if your red blood cells become dangerously low, and that's usually around the 8 or 9 mark, or if you have already a pre-existing cardiac condition, they may want you to get a blood transfusion, and which is kind of scary if you've never done so. But there comes a point where, you have to weigh risk versus benefit. And if it does become, a situation that's really taxing on your heart, or there's a chance that you may, lose consciousness of that sort of thing, you may want to entertain the idea of getting a blood transfusion. There are medications that can increase your production of these red cells by stimulating a certain hormone called erythropoietin. We only give that in certain situations where A, you don't have any cardiac dysfunction, or B, there's a long-standing, Yes, exactly. That's why I say it's for very, very specific situations, if it's appropriate for you. So again, it's for people that either have very, very long-standing anemia, don't have cardiac dysfunction, and, either can't manage a transfusion. So I'm trying to think of the odd case where you would have this, but we don't use it as much anymore. When I first started, very, very long ago, we used to give Procrit to anyone who walked in, because we figured, you don't have to get a blood transfusion, but it can cause clots. You're absolutely right. The other cell that might go down, thrombocytopenia. So this is a fancy way to say your platelet count is low. Now, if your platelet count is low, this is just a picture of petechiae, which is breaking of your little capillaries in your skin. So you might see these little dots. When your platelet count is low, you're at risk of bleeding. So if you're at risk of bleeding, you don't want to do anything that's going to be high impact. Now, I caveat this, don't use dental floss, because if you're an everyday flosser, I meet people who floss, I meet people who don't floss. Sometimes they decide, I want to start flossing now. That's not the time. Only because if you're not a frequent flosser, you're going to induce bleeding around your gums that may not be able to stop. You want to avoid using tampons if you can, enemas, rectal suppositories in general while you're on chemotherapy. You don't want to stick anything back there if you can avoid it. That's anything. Yes, anything. If you have any other questions about that, we can continue to talk about all the things you could stick up there, but don't do it. Any activity that's high risk of falls, high impact, jumping off of planes, bungee jumping, I wouldn't recommend. Again, don't put anything up your nose, anything. And blow your nose gently, because again, you can cause some epistaxis, nose bleeding. Now, if you're taking any steroids, and steroids are a big part of a lot of treatment programs that we have, try to take it with food, just because it can cause some bleeding in your stomach. And you want to avoid constipation at all costs. So use stool softeners and or laxative if that's appropriate for you. I know this is silly, avoid falls. Who actually puts themselves at risk of falling? I don't know. I fall all the time, so I don't know how you would do that, but be careful. If you use a safety razor, you might want to switch to electric if you can. Nail clipper instead of scissors. Use a soft toothbrush. And any platelets any medications that affect platelet clumping, like aspirin or aspirin derivatives, you may want to avoid those. Use Tylenol instead if you can. And again, this is not a traditional recommendation, but if you already have a very low platelet count, I've had patients who present with something called ITP, a low platelet count. If your platelet count is so low that we can't treat you, And there really isn't a chance that we can bring it up enough that we can treat you with chemotherapy. We may consider giving you a medication to boost your platelet count. Again, that's not the written use for these medications. But in a situation where you're on chemotherapy and we want to keep you on therapy, we may decide to use one of these. Yeah. Romoplastin. So with these, it's very similar in that it can increase your risk of clotting for a patient that has a platelet count over 100,000. But if you're presenting with chemotherapy and your platelet count is only in, the single digits or teens, that might be an appropriate use for the drug. Yeah. It depends on the type of therapy you're on. The blanket rule is about 100. That's ideally what you want to come into getting chemotherapy. But you're going to have patients in a range from 10 all the way to 400 plus. So that's something you want to, you want to look at your baseline. If you're coming in with a low count to begin with, your margin of error might be a little bit different for someone who has a naturally high platelet count. The other thing you want to look at is the other medications that you might be on. So if you already have a pre-existing condition like AFib, where you're taking Coumadin or some other blood thinner, we may not want to treat you below 100, whereas someone else who's not on any blood thinners, we may treat them below 50. So it really depends on what we're treating, the intention of the treatment. So if we're treating for cure, we're going to be a little bit more aggressive than if this is something that we're palliating, because we don't want to put you at risk of bleeding and, dying from a bleed for the sake of treating you through and being aggressive with the treatment. Any questions? Okay, now neutropenia. This is a big one. So with neutropenia, you have, I think I showed you a picture, but there are a few different types of white blood cells. Neutrophils are important because they help fight infection. They're the kamikazes of white blood cells. So what they do when they find an antigen, it actually goes, ingests the antigen, and takes it out of your body. So if you don't have these neutrophils at the front line, it makes it very, very difficult for you to fight off an infection on your own. You might hear your doctor say, we need an ANC. An ANC is called the absolute neutrophil count. Oftentimes, the golden rule for treating, you want an ANC of 1 or higher. Again, there is some leeway, depending, but you want an ANC of at least 1. So if you are neutropenic, and again, we expect to see this about 7 to 10 days after chemotherapy if you're going to have it. If you're neutropenic, you want to make sure you're washing your hands. So we're going to take this right back to kindergarten. Washing your hands seems like something really simple, but it's actually something that people don't do enough of. You've probably been in a bathroom or two where someone walks right out. So you want to make sure you're using hand hygiene really frequently. You want to be that annoying person that's carrying the antibacterial in your purse. Bathe daily. Again, sounds really basic, but a lot of people don't bathe as often as you think they do. You may have smelled them. You want to protect your skin from any burns or cuts. So if you have any open lesions, you want to make sure you're protecting that with a Band-Aid and keeping that area clean. And mouth care is really important. So you want to make sure you're rinsing with water or anything really, just to get the food out of your mouth, and you make sure you're not sleeping with extra food in your mouth. Again, doesn't sound, it sounds very basic, but it's not something that people do. Now, breathing exercises. This is going to sound a little funny, but normally in your normal day, you think about all the things that you do. Getting up out of a chair, walking up and down stairs, going from one end to the other. You go from not breathing very hard, like this, right now we're not breathing very hard, but the minute you start walking around, you go up a flight of stairs, you are breathing hard. You're getting that full respiration. And you do that several times a day, sometimes without even noticing it. And doing that helps prevent respiratory infections. So one of the reasons why pneumonia is so common in hospitals is because you're laying down all day. You don't have a great range of breath. So if you can, just take some deep breaths. Doesn't have to be every 10 minutes, just when you remember. Remember to take deep breaths as you go. Some people will say don't eat fruits and vegetables, don't eat fresh fruits and vegetables. I don't really subscribe to that. It's not really founded that it will affect you in any negative way. Just make sure you wash them. Wash the visible dirt off of them. And monitor your temperature. Now I work in transplant, so I have patients that have been treated multiple rounds of treatment, and they come to transplant, and I'm always shocked that they don't have a thermometer at home. You want to make sure you have a thermometer at home and call when that temperature goes over a certain level. For us, we say 100.5. Now, raw meat, fish, sushi, again, not something you want to keep on the menu. Carpaccio, just because, again, unless you're preparing it yourself, or even if you do prepare it yourself, it's hard to manage any microbiota that might be in them. People with colds, again, they're not always the best hand washers, so you want to avoid people with colds. Also, just handshaking. Everyone wants to shake your hand. It's okay to just put out your fists and give them a fist bump or say, I'm good. Sometimes it's okay to be rude, and it's not rude because why do you want to touch everyone? Sharing food utensils. Sounds very basic. Okay, don't share forks. But what about the forks that you don't know you're even sharing with people? If you're in a restaurant, you want to make sure that your utensils are clean. You don't know if you're not sharing with people if they don't tell you. So just make sure. Some people actually carry their own, which sounds silly, but at least you haven't been sharing it with people. Now with pets, especially cats, cats carry something called toxoplasmosis, which, again, you can catch if you're neutropenic. Toxoplasmosis doesn't have any obvious symptoms. Sometimes we don't even know that people have it until they're presenting with neurological symptoms. So kitty litter, just save that for someone else to do. Find a friend. When someone says, what can I do for you while you're sick? You say, change my kitty litter. And no live vaccines. So that's polio, varicella, smallpox. If you're about to get a vaccine, they'll probably ask you if you're able to get live vaccines. They'll tell you which ones are live and which are not, but these are the ones that are live. You don't want to get those until after your neutrophil count is up. And so if you do have an infection, typically you're looking at a temperature of 100.4 or 38 degrees C. Fever, chills. If you have diarrhea and you're not sure where you got diarrhea, what you ate to get it there, if there's any burning during your urination, if you have a cough, cold, any congestion, that's an indication that you may have an infection. Any redness or swelling around a sore, this is a reason to call your doctor right away. I can't tell you how many times someone has said, I didn't want to bother you. I didn't think it was a big deal. I just felt a little cold. No, it's a really big deal. Because if you don't have a neutrophil count, you cannot fight off infection on your own. And it is a reason to go to the ER. As much as an inconvenience as it is, we want you in the ER as soon as possible so that we can start antibiotics and help you fight off that infection. And again, once you have an infection, make sure you're taking your antibiotics, whether you're inpatient, outpatient. Finish the entire bottle. Same hand hygiene. Keep that the same during your infection. Clean any cuts. Don't go picking at pimples. True story. I had a patient on active therapy, and his girlfriend did not like the fact that he had a huge pimple on his face, and so she went to pop it. And that got really infected, and he ended up in the ER, and he was in the hospital for 2 weeks from this pimple that she just could not bear to see. And then they broke up. So was it worth it? Okay, so nausea and vomiting. This is a biggie, especially because, again, a lot of these drugs are going to affect your GI tract and really irritate your stomach. So There are so many drugs on the market now for nausea and vomiting. We can go through the whole list: Composin, Zofran, new combinations of Prepitant. Not everything is going to work for everyone. But what I can tell you is that you should not be vomiting. You should not be throwing up uncontrollably. None of that should be happening, because we have ways to mitigate that and mitigate it well. So if for whatever reason the regimen that you're on is not working for you, you need to switch it up, and switch it up sooner than later. Because, while, it's not just a nuisance. This is going to affect your nutrition. It affects how well you're able to fight off infections, how well you're able to fight off the cancer itself. So we want to make sure that you're comfortable and you're happy. So again, if it's not working, change it. A big question here. People say, well, what about marijuana? Marijuana's fine. Totally fine with it. What I don't advise is you smoking it. So if that's what you like, we have it in pill form, Marinol. You can eat it. I don't know where to get it. I am not a source. I don't sell it. But if you want it, don't smoke it. There are other things that have worked for patients of mine: acupuncture, acupressure, self-hypnosis, peppermint oil, ginger. Whatever works for you, continue to use it. Now, diarrhea is a side effect with some chemotherapy medications, again, because of the irritation of the lining. If you have diarrhea, and we know for sure that it is not an infection, Imodium or any antidiarrheals, if you need to progress to a prescription, you can. And in the meantime, you want to drink enough water. Get hydration in office if you need to, if you're not able to keep down water. You want to cut down the fat in your diet, cut down the spicy foods. Brat diet is a basic: bananas, rice, applesauce, and toast. But in general, just want to keep it bland, keep it low fiber, and avoid anything too greasy. So if Imodium is not working, just make sure we know about it so we can give you something a little stronger to stop it. Now, some of the oral medications do cause diarrhea, like Zytolake, Ibrutinib, or Revlimid, if you've ever been on one of those. Taking it at night actually helps to mitigate the diarrhea. So if you take that at night, usually it settles the stomach a little bit better. And you want to take those medications with a snack if you can. Again, something bland, like crackers. And on the opposite end of things, constipation. So I think I mentioned vinca alkaloids. One of the big side effects is constipation. You could also get constipated from pain medication or some of the other supportive care, like the anti-nausea medications can cause a little bit of constipation. So again, you want to increase your fluid intake, increase your fiber, and you want to use Colace and Senecot if it's available. Miralax is probably my favorite laxative. Who says they have a favorite laxative? I do, because it works. It doesn't irritate your stomach. It doesn't cause any cramping, and you can adjust the dose as you see fit. Now, if you become constipated, I know not everybody goes every day, and that's okay, but you may want to keep a calendar of how often you go, because if a week has gone by and you haven't pooped, that's a problem. That can actually land you in the ER. It can also cause bleeding if you're trying to expel something that's been there for too long. So it's something to take seriously. It's not something just, throw under the rug. I talk to people about their poop every single day. We all do it. So if you're having any issues, please be vocal about it. Now, neuropathy. Any questions so far? I'm talking. Okay. Neuropathy. If you ever heard anyone ask you if you have numbness or tingling in your hands or feet, this is a side effect of drugs like the vinca alkaloids that I mentioned. The best way to prevent and mitigate neuropathy is to stop it before it starts. So if you start to notice any transient numbness or tingling, that's an occasion to give us a call, again, right away, so that we can adjust the dose for a dose that works for you. Because once it gets to the point where Neuropathy is constant. It doesn't always go back to normal after the end of therapy. And if it does go back to normal, it takes a really long time. So again, if you notice any numbness or tingling, you want to call us right away. Some patients come in with neuropathy if they already have had some sort of issues with like diabetes. So we want to make sure that we are keeping a close eye on it, especially in the wintertime where you may not be able to sense heat and cold. So again, managing it, again, avoiding falls, avoid falls, hold the handrail. If you're outside gardening, cooking, or doing anything where you may not feel cuts, you want to wear gloves and wear shoes with rubber soles. This is not a great time to wear high heels. And again, avoid temperature exposure, especially to the cold. Now, there are some vitamin regimens that anecdotally work on neuropathy. Again, they work really slowly, but there's no downside in taking them. That's a B vitamin complex cocktail there. Also, if your neuropathy is really painful, you may want to consider a medication to help mitigate the neuropathy pain, like Lyrica or Neurontin. They also have topical medications that people tend to like a little better that contain Neurontin and anti-inflammatories. So you might want to talk to your physician about a compound cream that will help with neuropathy pain. And that way you don't have to take an extra pill. So alopecia is the most obvious side effect of regimens, like especially R-CHOP, anything that uses a vinca alkaloid. I mean, I can tell you all day long, oh, your hair will grow back and everything will be fine. But that's really, I mean, it's a hard thing to do, to go through losing your hair. Whether you're a man or a woman, doesn't really matter. But it's something that we can't expect, and you want to at least prepare for it if you can. So if you know that you're on a regimen that's going to cause alopecia, you may want to cut your hair shorter before moving into treatment. You want to use mild shampoos and conditioners. Avoid overbrushing. Avoid over shampooing and combing. If you want to purchase a wig, I say the easiest thing to do is try to match your hair before you start treatment, because in that way you can actually get a swatch. Some people have actually made wigs with their hair if they have enough of it. Insurance companies will reimburse you. Some do. The key is using the right language. So you want to ask for a prescription for a cranial prosthesis, not a wig. That would actually help with reimbursements. I know it's silly, right? But you know what? Fewer companies reimburse you than before. But whatever you call it, use the right terminology, get a prescription, and then you may be able to get reimbursed for the costs of at least part of that wig. Some patients have asked me about ice caps. Has anyone heard of those caps? For lymphoma, I'm not a huge proponent of ice caps because lymphoma is a systemic cancer. It's not like breast cancer where it's only in your breast or, some other sort of solid tumor. So you may want to make sure that you get full penetration from head to toe. So that's why I don't necessarily recommend it. So mucositis is a fancy way of saying mouth sores. So mouth sores, again, because the lining of your mouth is so sensitive and those cells grow really quickly, mouth sores can happen, especially for drugs like pralatrexate. Typically, you'll see this peak about 3 weeks after the start of treatment. And in the end, while it doesn't sound like something very significant, it can be really painful. So if you do have mouth sores, you want to mitigate the pain because it can be painful. So it's okay to ask for pain medication, whether it's an anti-inflammatory or something a little stronger. Mouth rinses are excellent. So we do use things like Magic Mouthwash, which is a mix of Benadryl, lidocaine, and Mylanta or everyone has sort of a different recipe, but you want to use those as well to mitigate the pain. You want to avoid alcohol, smoking, spicy foods. And if you're not able to eat, hydration is really important. So at the very least, you want to make sure you're getting liquids down. And if you can't do that, IV hydration is a good use for this. So here, cryotherapy, I'm a little bit more lenient on. So if you're getting chemotherapy while the chemotherapy is flowing, you can chew on ice, and that helps prevent it. And again, just basic oral hygiene, acyclovir. Even if you've never had a cold sore in your life, this may be a point where one might pop up if you just have an underlying dormant herpes virus. So you want to stay on acyclovir as a preventative measure while you're on chemotherapy. So again, with just basic oral care, increase your fluid intake. No one's ever going to tell you that drinking water is a bad thing during this. So 8 to 10 glasses if you can. Again, use a really soft toothbrush. You want to rinse with salt and water if you're feeling dry. You can also use moisturizing rinses like biotin. Again, spicy, acidic foods, anything that's irritating. And keep your lips and your mouth moist if you can. And this, again, just floss. If you're already floss, you can continue to floss. If you're not a flosser, don't start now. You can start after. And if you smoke, please try to quit. Try your best. Other thing is, before you even start therapy, if you have time, you want to take time to see your dentist. Few reasons. One, while you're on therapy, getting a cleaning is not advised because one, it can cause bleeding. Two, and it can introduce a lot of bacteria into your system. So especially if you're neutropenic, you do not want to get a tooth cleaning. Excuse me. So if you can do that before you get started with treatment, you'll be in better shape. Two, there are some medications that we give to help boost your bones, and those can cause some issues with your jaw. So you want to make sure that your jaw is fine, or there are no issues with your teeth before you get started if you can. And again, if you have an infection or an abscess in your mouth, that can be a pretty big deal, and that would be a reason to either stop or delay your treatment. So if we can find these things ahead of time and mitigate them, it'll be a better smooth sail right through. Now fatigue, that's the biggest one. I know folks, used to say, "Oh, I'm so tired. I'm so tired." Like, people don't really understand. Like, it's not tired. It's a really tired to your bone where you don't really want to do much of anything. And that's not something we take lightly. The fatigue can come from all different types of sources. It can come from anemia. Your red blood cells aren't so high. Maybe you're not feeling so great. Maybe you're a little bit sad. This is a lot. It's a lot to deal with. Perhaps you're not sleeping as well. There's so many reasons why you may not be sleeping as well. Perhaps stress. Maybe it's being up from steroids or some of the medications that you're on. You may not taste things. They don't taste as good. You may not be eating as much. Sometimes your thyroid might be affected by the treatment, and that can cause fatigue. If you have infections, if some of your levels are not so great, or maybe there's something going on with your disease. So if you're feeling more fatigued than usual, fatigued in a way that's getting in the way of your everyday life, this is something that we need to know about so we can help you with and figure out what the big sources are of your fatigue. You're bound to be somewhat tired. It's not going to be like normal, but you want to make sure you're getting out of bed every day. And if it's at the point where you're not getting out of bed and you're not doing the things that are important to you, then we need to get involved and help you get back up and running. So as far as moving goes, the more you move, the more you move. The more you sit, the more you're bound to sit. It's going to be harder to get up and running and get the ball rolling. Inertia is a beast. So if you can get out, walk when you can, Climb the stairs when you can. It's going to be easier to get back up and running once you have that energy going. Sleep is huge. If you can, again, I know this is difficult, but if you can really put yourself on a schedule and make sure you're getting enough sleep, it's super important. If you're having trouble sleeping, again, this is something that we want to know about and figure out why it is that you're having trouble sleeping, what it is that's getting in the way so that we can help you through it. Hydration is, again, big. You want to make sure you're drinking enough. If you're not drinking enough, if you're drinking too much, if you're going to the bathroom at night, sometimes that can get in the way of good sleep. And if your heart function isn't so great, so some people can't sleep flat because of heart function, and that might get in the way of a good night's sleep. So if, again, this is different from what you normally expect, if you're short of breath, this is a reason to give us a call and let us know so that we can start figuring out what the source is. But I'm still tired. So consider medication if we've gone through every single source and we really can't figure out the source of your fatigue. Sometimes a little boost from something like Provigil, Adderall, Ritalin have helped patients in small doses, sometimes with breakfast and with lunch, just not so it's affecting your sleep pattern, but enough that you can get up and do things. If it means getting to work, sometimes it's a good short-term fix until, your anemia is recovered or, you're back to sleeping as well again. So in the long term, once you're done with your chemotherapy treatment, there are side effects that can happen much longer, and those we can talk about over time, but you want to enroll in survivorship programs if you can, to talk about things in the long term. Maybe there are issues with fertility, with your skin, your eyes, GI symptoms. You want to make sure you're getting a yearly follow-up or following up in the long term. I mean, once we're done, it doesn't mean that you're exactly done. We want to continue to track you and see how you're doing and see if there's anything that we can mitigate, again, in the long term, years from now. So, in conclusion, you will not experience all these things, thank goodness. Some things may be enhanced because you're not coming in as the healthiest person, but that's okay. We're here to help you through that and adjust your medications as we see fit. And again, let us know what's going on so we can help you. Again, you are a party of one. You know yourself better than I ever will. So it's up to you to share what's going on so I can help. We can help. Any questions? Well, again, thank you for spending your Saturday with me. I hope you found this useful.